Good afternoon, respected chairpersons and dear delegates. This case was done by Dr. Michelle Henry live at Madras Medical Mission during ACT, which is Advanced Cardiovascular Therapeutics, our annual conference. The patient was a 45-year-old male, diabetic and hypertensive. He had dyspnea on exertion class 2 and claudication of left upper limb. A coronary and peripheral angiogram was done. The coronary artery angiogram showed non-critical double vessel disease involving the distal RC and circumflex, which needed only medical therapy. His left subclavian artery was 90% blocked. His right internal carotid also had a 90% block. And we had to do the angiogram through radial because both the pulses femorals were not felt, but he was asymptomatic in the lower limb. So this is the left subclavian artery showing 90% block, and you can see another 90% stenosis in the right carotid artery. And since both the common femorals were not felt, we had to do this through the radial approach. And this is the total occlusion of the abdominal aorta. So through left radial approach, the arch was a type 3 arch, so there was difficulty in hooking the right innominate artery. So we had to take a VTEC catheter, 5 French VTEC catheter, and then engage the carotid artery. And then an angiogram was done. This is the intracerebral pictures in the AP and lateral view, showing no intracranial disease. Then through the VTEC catheter, which was used to engage, a wire was parked into the external carotid artery, and then the catheter was exchanged for an extra long wire with a 7 French 65 centimeter bright sheath, and the sheath was placed well before the lesion. An EPI filter wire was deployed, which you can see on the top end, and then the lesion was directly stented with a 18 to 40 mm precise self-expanding stent. It was then post-dilated with a 5 into 20 wire track 14 plus balloon, and the filter wire was then retrieved. The final angiogram showed a good result with good flow, and intracranial shots also showed that there was no vessel compromise. The same bright tip sheath was then pulled back to the left subclavian artery just above the subclavian lesion, and a 035J tip Teflon wire was passed into the arch, and then a direct stenting with 7 into 27 mm EV31 was done. And this is the final result showing a good patent subclavian artery. Thank you.
What are your exact indications for a radial or brachial approach? If you compare with femoral, personally, I have done 1,200 procedures. I have used radial or brachial approach maybe in 10 cases, because by femoral approach we can do everything. And if you have a problem, the problem is not the way. It's easy to do radial brachial. It's not the problem. The problem is when you have a complication. If you had, for example, an arterial rupture, you have to place a cover stent. How do you do by radial approach for a carotid of subclavian? I know it's very rare, but it could happen. What do you do? So what are the exact indication. For me, very rare.
This patient had a total occlusion of the abdominal aorta.
Yes, okay. But, so, what are your indication for radial approach or brachial?
Other indications.
Yes, in practice.
Yeah, I mean, here Takayasu's arteritis is common. So, in sometimes Takayasu's, there might be involvement of both the lower limb vessels or an abdominal involvement, abdominal aorta involvement. So, that's another place where we need to do. I mean, other than atherosclerotic and Takayasu's, I mean, I don't know.
I think, Michelle, those who are really enthusiastic about radial approach, and it seems to be getting more and more popular, the patient can walk off the table, ambulate right away, and you don't have any of the potential growing problems. I think that's what the proponents are saying.
Yes, but with puncture site closer device, now also you can ambulate a patient 1-2 hours after. So I think reduce also the indication for peripheral procedure. I don't speak on coronary procedure, it's totally different, but for peripheral procedure in general. Because we have puncture closer device, so you can ambulate the patient, can leave the clinic the same day, no?
In our place, our fellows would agree with you, because I've tried to encourage the radial approach, but it just doesn't seem to be very popular at our institute. So you're probably you're in sync with what we do.
Okay, Mr. Moderator.
So in this patient, internal carotid artery, it cannot be seen in case of Takayasu's arteritis. It must be atherosclerosis.
No, this is atherosclerosis.
Yeah,
No, he asked me another indication for radio.
We run out of time for the presentation of this particular case. Thank you very much, Dr. Aylin.